Hi, everyone. Thanks so much for joining us today. We're going to have a nice conversation about COVID-19 and medications and what is safe in Duchenne. We've got some great speakers joining us today to talk through some questions that we've received from all of you. I know many of you were able to join us last week on our webinar about general Duchenne and COVID-19 implications, and it laid a really nice framework for all of us. So today we're going to build upon that, and we're going to talk about medications, both prescription medications and over-the-counter medications, what's safe, what's not, and how to make sense of it all, because there's a lot of information and it can be really confusing for us. So we've got a really great group today. We have Dr. Chet Villa. He's a cardiologist at Cincinnati Children's Hospital. We also have Dr. Linda Craik from Nationwide Children's Hospital, also a cardiologist. And we'll go ahead and speak to some of the different cardiac implications of coronavirus as well as the medication implications, since there's been a lot of information on the news as of late. Following them, we'll have Dr. Mana Spadina. She's a neurologist at Nemours DuPont Children's Hospital in Wilmington, Delaware. She'll talk about some steroid implications and stress dosing and what that looks like. And then we'll have Dr. Hemant Sanani talk about pulmonary implications, over-the-counter medications, and a variety of information in that regard. So we'll go ahead and we'll get started. I'm going to go ahead and pass it over to Dr. Villa to talk about the heart and cardiac medications in COVID-19.
Terrific. Thank you all, and thank you everyone for joining us. This topic has received a lot of conversation in the news recently, and we've had a lot of families reaching out, so it's glad to be a part of this, and thanks to PPMD for putting it on so that we can have a broader reach for a lot of questions that I know our families are having right now. Just as a basic for why or how the heart might be affected in COVID-19, one of the things that we know is that age, as well as a variety of cardiovascular risk factors, are associated with severe disease. Now, the most important part about this for almost all of our families is age is a significant predictor. Even though some of our patients do have things like diabetes or prediabetes or high blood pressure as a result of some of their therapies, age is a significant predictor. The other thing that is important that has started to come up is that we know, just like with other viruses, this coronavirus can actually have some cardiac impact. So there are a small number of cases where myocarditis or viral infection of the heart have been described. However, the biggest point there on the bottom is young children and young adults are at significantly lower risk than most of what we have heard on the news and in the press. That does not mean there are zero. There are a variety of people who have experienced it, some of whom have received a lot of news, both in the typical news and on social media, that are young and have had severe complications. But in general, those numbers are pretty small, and I think that's important when we talk about the risk benefits of some of the medications and therapies. So the biggest part that has really come up has been around ACE inhibitors and Arbs. And for a little bit of background, those medications for a lot of you, those would be things like lisinopril, enalapril, valsartan, those sorts of medications. The reason those have come up is there is a protein called ACE2, which is found on the outsides of a lot of cells in the body, most notably the lungs, heart, kidney, and intestines. And that is one of the targets for how the coronavirus attaches to cells. It is only one of many parts that go into how it attaches to cells, but as a result of that, it led to a variety of questions from medical professionals, researchers that asked the question, could some of the medications that we use either be a therapeutic target or potentially worsen things? And as people were starting to come up with these ideas, unfortunately, a lot of that information got out and was being discussed as if we knew exactly how a lot of this affects those cells, as opposed to we're still trying to figure it out. And so when we talk about it within the medical community, we talk about how ACE inhibitors may potentially worsen or improve the overall outcomes in the setting of COVID. There are actually a couple theoretical positives for things like ACE inhibition. There was some early data in the 2000s when SARS was coming out that suggested both in animal, or mostly in animal studies, that ACE inhibitors may actually improve lung-related injury in the viral infection. More recently, a lot has come out about the theoretical negatives of ACE inhibition because ACE inhibitors may increase the levels of that protein. And so that led to people asking, well, should we stop our ACE inhibitors right now or our ARBs because this may potentially worsen viral infection? Well, I think whenever we discuss that, just like with any other medication, we talk about the risks, benefits, what is known and what is not. All of this stuff that has come up has really been theoretical within the community. We are trying to answer this question as we speak, and there are clinical trials going on a lot out of China and now in the rest of the world as the infection has gotten worse. But all of those are theoretical right now. What we do know, and this is really important, is the benefits of ACE inhibitors and ARBs in therapy for Duchenne and for dilated cardiomyopathy. Those medications are used to control blood pressure for patients who have high blood pressure, and that is a risk factor for doing worse if you do get the virus. We do know it also improves long-term heart outcomes in Duchenne. And there are multiple studies that have shown that stopping this therapy can cause the heart function to decrease in as short a time as days or weeks. So I think it's really important to know these are a lot of side effects that can happen if you come off for a potential theoretical benefit. And so really the take home is, and this was so important that basically every major cardiovascular society came out to address this issue because it really did get a lot of information and say basically there are no experimental or clinical data right now suggesting that there are positive or negative effects of ACE inhibitors, ARBs, or these other antagonists. This would be of things like eplerenone and aldactone if you're on those medications in COVID-19. And there was a call to try and answer it very quickly. So a number of groups are trying to answer this, but right now everything is theoretical, both positive and negative. And what I would stress we do is go for what we do know makes a difference in cardiovascular outcomes in Duchenne, and that is continue on your medications for right now. If there are questions that you have about your individual case, because this is the broad recommendation, I would call your cardiologist or your provider who's actually prescribing those medications and ask them. And then the one last point to make is, so as I said, there was a call to try and figure out how we can get data to everybody as soon as possible. There are a couple of ways to do that. One, through PPMD, which has been terrific. I use their Twitter site quite a bit for distribution, and I think it's really helpful to get things out relatively quickly. We also have a group of heart failure and heart transplant doctors that are meeting to discuss a lot of the implications for what this means for children and young adults who have heart disease. Dr. Kripe and I are leading the Duchenne-specific component of that, and we would hope to release any data that we're getting through that group as soon as possible because we know it's quite a stress for all of our patients and families, and we are going to try and be both quick about it, but also getting you the best data that we have available. And I think the last part is, while a lot of this is focused on our boys and young men with Duchenne, I think one of the things all of us would endorse is a major determinant of all of our outcomes is keeping families healthy and safe. Our caregivers are responsible for so much in terms of maintaining day-to-day medications, therapies, all those sorts of things. And for mothers, fathers, grandparents, all of the people who play a significant role in caring for all of our patients, keeping yourself safe and healthy is just as important as a lot of this stuff because you are so integral into maintaining health. And so I think with that, I will punt back over to Rachel and to Linda.
Great. Thank you so much, Dr. Villa. That was really helpful. It was incredibly clear and concise. I think it can be really hard when we watch the media and we see things about these different classes of medication and we think, oh, I or my child is on that. I need to be worried. I need to be, really concerned. And so I think that was just really, really clear and very helpful. And hopefully it decreased a lot of anxiety for our some of our families on the phone. At this point, I'm going to go ahead and turn it over to Dr. Craik, who is going to share some information about clinical practice, some of the questions that she has seen, some of the concerns that she's heard, and how she's been handling that with her patient population. So Dr. Craik, go ahead and take it away.
Okay, thank you, Rachel. And Chet, that was outstanding. I, in the interest of not wanting to be redundant, I will move forward and talk about some issues that families may be thinking about as they think about the care of their sons. I think the most important thing is to appreciate the fact that COVID-19 is an infectious disease. And so there is nothing unique about COVID-19 that is specific to Duchenne that we know about. This is a disease that is affecting every individual worldwide. And so I think when we think about it that way, we appreciate the fact that our approach should be really into how can we keep patients with Duchenne safe. But the same things that apply to every other patient population apply to Duchenne. So other things that you may be hearing from other disease-related communities, I think apply to Duchenne. And so staying healthy, as all health departments and all the news media is really emphasizing at the moment, is really all about reducing contact with the virus. I think that it cannot be said over enough. I think we're overwhelmed by that now on social media, in the communities, amongst our families. Keeping that social distance from each other, making sure we're washing our hands, trying not to touch our faces, is really going to be critical to keeping our families safe. And as Chet so eloquently pointed out, I think to continue all cardiac medications. There really isn't any data at this moment in time to support the stopping of ACE inhibitors or angiotensin receptor blockers. I think that the data that has been published in the publication that everybody refers to is potentially intriguing and interesting, but not the data that we need to globally potentially increase risk to the patient population by stopping these medications. The other thing I'd like to address are concerns about patient visits at this moment in time. Many centers are working, I know our center is working nonstop day and night to get up the telemedicine capabilities of our institution. And we, I think within the next week or two, are going to really expand our telemedicine options. This, I think, will be revolutionary for the field of medicine. I think once this crisis is over, I think telemedicine will be something that we will have forever. I think this will tremendously benefit our patient population because, as everyone knows, sometimes it's difficult to get to hospitals because of transportation issues or clinic visits because of transportation issues. And now this will increase the access to our providers extensively. So what I would encourage families to do is to contact your medical center and see if telemedicine is going to be an option in the near future. And if you have any questions or concerns, if you could potentially participate in that. So if problems that aren't urgent, do call the cardiologist and try to avoid going directly into the emergency room. Emergency rooms are overwhelmed across the United States at the moment, and obviously there is a high risk of contacting individuals who may be infectious. So for the Duchenne families, I would say if you can avoid the emergency room whenever possible, and I'm not saying don't ever go there, because obviously if you have a true emergency, then by all means, go in. There may be a need to call the emergency room prior to going in if you can, to see what options that they have available for somebody who may not have an infectious issue that is urgent, and they may actually have separate entrances for people who have non-COVID related illnesses. So I would explore that before going in as well. One thing also would be to anticipate medication refill needs. and recognize there may be delays at the pharmacy. So, I think a number of pharmacies are working with insurance companies to refill some prescriptions even another month in advance, sort of batch the visits that you're going to be making to the pharmacy potentially, and get your medications. Think about those things ahead of time. There's one other issue that I'd sort of like to address that I didn't include on the slide, and it's the use of chloroquine and and azithromycin for the treatment of COVID-19. I think that we've all seen in the press that these two drugs have been potentially put out there as reducing the viral load during an acute illness, and I think that, like the information with regards to the ACE inhibitors, I don't think there's substantiated data to support that, and there's potentially risks associated with using those medications off indication. I know that in the United States, a number of individuals have had significant morbidity and mortality associated with using high-dose chloroquine. So I would not advise that under any circumstances at this point. I know that pharmacies are very wary that people are trying to get prescriptions for that, and I think are really shutting that down pretty much. Not to mention the fact that, as I understand it, chloroquine is now back-ordered. It's also important to note, in the same way that many medications and things are important for the Duchenne community, chloroquine is important for some patients for their rheumatoid arthritis, and they're now not being able to get those medications. So I think we ethically need to respond to the use of these medications for that reason as well. I think I'll stop there and let the next speaker move forward.
That was great, Dr. Craig. Thank you so much. Those were some really wonderful practical tips about things that you're seeing, and I think we all really appreciate some of those really fantastic take-home messages. As a quick reminder to everybody, if you have questions for Dr. Craig or Dr. Villa about these cardiac implications, please do not hesitate to use that chat box in the lower left-hand portion of your screen. You can go ahead and submit questions there, and then once we get through our next two presentations, we'll go ahead and open it up for questions. So if you want to go ahead and plug that question in now before you forget, go for it, and then we'll go ahead and circle back. So at this point, we are going to hear from Dr. Mena Scavina. She is a neurologist at Nemours DuPont Hospital for Children, and she's going to talk to us a little bit about steroids particularly. I know that we covered that in last week's webinar, but it seems like it's a subject that we just keep hearing questions about, so we want to go ahead and provide as much clarity as we can on that topic. So Dr. Scavina, I'll go ahead and turn it over to you.
Great. Thank you very much. Thank you for inviting me to speak today. And if you could move my slides along, that would be great. So I think that one of the questions that's come up is the concern that majority of boys may be on steroids and how that compromises the immune system, and should perhaps it be decided to just stop steroids. So I think one of the take-home messages today is that at this time, we don't feel that stopping your current steroid regimen is recommended. Even though it does immunocompromise an individual, right now to stop it would potentially put an individual at risk of adrenal crisis, and we'll talk about that a little bit. And potentially, if they were to become infected with the virus, make the matter even worse. So I think that for now, like so many things, like continuing with your cardiac medications, continuing with all the prophylactic or measures of washing hands and following all the CDC guidelines, keeping with your routine steroid treatment is where we would like people to stay, whether that be daily or weekend. And I'll talk about that a little bit as well. I think a number of families, as this was all progressing, did reach out to me to ask about additional doses. I think making sure you have plenty of medication at home is important. For Emflaza, those are shipped to you, and I have not seen any disruption in shipments to families, but I would say from my standpoint, we have limited individuals in the office helping with our authorizations and such. So to just stay on top of your dosage, if you are aware of your authorization dates and when those might end, so that you can contact your office if a refill is not coming to your home, if you feel that you might be reaching your authorization limit, just to make sure that you have continued medication without any disruption. I think that's really important. Okay, next slide. Next slide, please. One of the questions, and this is something that can be found on the PPMD website under steroids use, is adrenal crisis. And that is something in which our bodies make this stress hormone, cortisol, and that is needed for things such as fighting an infection, fighting stress of a surgery. But when we take those steroids, that kind of takes a back seat from the adrenal gland. And so stopping a steroid abruptly puts the body in sort of a shock system, and that's what we want to avoid. And so I bring this up not for any fear factor at all, but to really just emphasize continued medical regimen of the use of prednisone or Emflaza. Okay, next slide, please. Next slide, thanks. One question that's come up is about stress dosing, and many of you may be seeing an endocrinologist who's managing some of this. In some clinics, it may be the neuromuscular person. I've been very lucky with endocrinologists who've sort of taken the hold on this. So I would ask you to contact your endocrinologist or your neuromuscular specialist about stress dose if you don't have that at home. And PPMD has a wonderful site with the P.J. Nicholaff steroid protocol, and this is to be utilized if there is a need for increased dosing, if there's a fever or vomiting or illness for which your body may need additional steroid. The PPMD emergency cards have these on there. Hopefully you all have that. There's, I believe, also the app. And I know that families in the past, even before all of this, that have been hospitalized at an outside facility that perhaps is not aware of this or does not take care of a number of individuals with Duchenne, we've referred them to this for the stress dosing protocol, and it's been very helpful. So if you find yourself in an emergency room or with a provider who's not familiar with that, this is a very good resource, so I ask you to just be aware of that. And if there's any questions, PPMD, in my opinion, has always been a great resource for disseminating this information if there's places that need additional help with it. Okay, next slide, please. This is just a picture of the P.J. Nicholaff protocol, and it's not to be memorized or anything like that, but we sort of look at the stressors sort of as minor, moderate, or major, and there are different doses depending on those different stressors. If the stress dose can be taken orally, that's preferable, and if a child is vomiting, cannot keep it down, there is intramuscular stress dosing, and again, there are different doses depending on age. And what I've seen as well is that different institutions, endocrinologists may have their own protocols, so I do ask you to reach out to them for those doses. Next slide, please. The next question that came up was about infusions, and I have received these myself, where families are asking if I do receive a weekly Exondys or Vyondys dose, should we continue those? And the way we look at this is that this is really not something we believe to be elective, but something that we don't want to interrupt or delay. So with everything that I can say, I would like to have families continue, and that's what I've recommended to my patients. I know Sarepta has put out a statement. It's on the PPMD website in terms of things that they are recommending and putting in place for the nurses that go out to the home with all the CDC requirements, hand washing, protective equipment, following all those guidelines if they are ill or have had contact with individuals that are ill. But I can understand how it's very scary. We are promoting social distancing. I know I haven't seen another individual other than my children and my husband and my dog for the past 2 weeks working from home. And so to have someone enter your home who you may not know what their contact is and has been, or if they're potentially going to develop a fever and virus, it's a scary proposition. But we would like you to maintain dosing if possible. Please contact Sarepta or your neuromuscular specialist if there are concerns. I know that some individuals are doing this in infusion centers. Tomorrow, myself, we have an individual who's receiving an infusion. I've contacted we call it a day medicine unit, and they have their own protocol in place. They're taking temperatures of everyone that enters. They are limiting it to one individual who can stay with the child. If someone has a cough, fever, other illness, they are not allowing them in. And so I know that can't guarantee, but we're doing the best to maintain the treatment with reducing the risk. And so that individual has chosen to continue to come in for their infusion. I'll be there. I'll make sure, too, that those things are in place and do the best that we can. So that's sort of the take that we have. And as far as I know, there's not been any interruption also in the distribution of Exondys or virus. But again, please speak to your specialist about those if you have any additional questions. I think there's one more slide, but I think I covered everything pretty much in that. If you are concerned about someone that does enter the home to provide the infusion, I guess have those courageous conversations with them and discuss your concerns, see if there's anything, if it can be rescheduled, if you're concerned that your child may also not be well. Contact your neuromuscular specialist to see if it can be postponed for a week or two. So this is, I think, a work in progress and something that's fluid, but the bottom line is we don't want to interrupt steroid use and we don't want to interrupt infusions because we do feel that those are the two things we have to continue to treat individuals with Duchenne. Thank you so much.
Thanks, Dr. Scavina. And I think it would be helpful to kind of reiterate, I know we're getting a lot of questions and a lot of concern around bringing outside people into the home to administer these infusions, whether it's your son receiving Exondys or Vyondys, or if there's some sort of other underlying health condition that is affecting you in your home. We hear you, and I know that this is really scary and it's really complicated, and it can induce a lot of anxiety when we're trying to isolate and socially distance ourselves. Please know that this is something that we're thinking about, something that we're talking about internally, and keep your eyes out. We are going to try to put together an additional webinar specific to clinical trials, access to approved therapies, what in-home infusion can and should look like. There's not a really clear-cut answer, but we want to provide you with as much information about that as possible. So, like I said, keep your eyes out. That's definitely a conversation that we're going to continue to have and continue to try to answer those questions for you the best as we can. So with that, I'll go ahead and turn it over to Dr. Sanani. He is a pulmonologist, and he's going to talk to us a little bit about pulmonary considerations with COVID-19 as well as OTC medications, what's safe and what's not. So take it away for us.
Thank you. Thank you so much. So independent of any type of neuromuscular disease, symptoms with COVID infections can range from mild to severe, regardless of the type of neuromuscular disease. And they can range from mild nasal congestion to much more ICU-like situations. And so inherently, this isn't any different from any of the other cold viruses that you've heard about. There is no current data at this point that supports the idea that neuromuscular patients are more likely to have severe acute respiratory syndrome or the SARS that we hear about associated with the corona infections. When you look at the standard of care for therapy in any of these viral situations, they're all fairly consistent. I believe in the major F's that come into play, which is fever, fluid, and foods. These are really important in addressing the needs in these areas to prevent fatigue or respiratory fatigue. As with most respiratory infections, there's going to be cough, and with cough comes exhaustion. So controlling fever actually helps reduce the caloric burn. So we advocate for the use of Tylenol and Motrin typically, although Motrin now ibuprofen tends to have fallen out of favor in the current environment. So fever control with tepid sponging or Tylenol is very, very appropriate and helps reduce the sense of exhaustion, maintain fluids and hydration. And this is really important because anytime anybody has a fever which ends in sweats, the combination of the fever and the sweats leads to increased what we call insensible losses. And when you are on a scale, when you're progressively dehydrating, it's really a concern because mucus secretions tend to get thicker, and thick mucus does not move. So hydration is really important. No one's going to starve if we miss a meal, so you can always do light foods. I tend to recommend easy to digest carbohydrate-based foods because when you start adding fats delay gastric emptying or emptying of the stomach, and it really makes it harder for the body to quickly absorb the carbohydrate portion of the meal from the stomach. It has to get to the small bowel, and to take those sugars directly to the muscles. I think it's important to realize that whenever we have any form of muscular dystrophy, we have a reduction of muscle fibers, but not just that, we also have reduction in the amount of sugar stores that are available on short notice for energy metabolism in those muscle fibers. If you think of someone who lifts weights aggressively and develops muscle bulk, that's not because of an increase in number of muscle fibers. It's an increase in the size of the muscle fibers because of the amount of sugars packed into those muscles, so that the energy source is available immediately. So it's important to replenish sugar stores for our children with neuromuscular disease, particularly when they have fevers. Fevers increase the heart rate and the breathing rate, and that the latter is what contributes to increased insensible losses. We've heard already about some risks associated with ibuprofen, and this is because ibuprofen has been associated with an upregulation or an increase in the number of receptors to which COVID binds, and people feel like that can actually increase the risk of dissemination or the spread of infection faster. Airway clearance therapies need little introduction. I think we always are worried about secretion burden. And I want you to think about this as a twofold issue. One is the secretions that drain from the upper airway, and the second is those that are originating in the lower airway. So very often we have this complaint. Our children have had a cold, but there is this lingering cough, which is worse when they lay down at night, and it becomes hard to recover from. Well, the problem is that you tend to have a residual postnasal drip, and I'm very supportive of the use of Afrin or a nasal decongestant as a nasal spray if there is no cardiac contraindication. A spray on each side of the nostril, repeated after about 5 or 10 minutes after blowing and clearing the nose, is really helpful. In the first 24 to 48 hours of a cold, there is a fair amount of rhinorrhea, which is nasal drainage. It tends to run like water, often families will say. And that's really a problem because any kind of nasal spray you apply is going to drain and dilute out very quickly because of profuse nasal drainage. And that's why I typically recommend blow your nose, take a spray, let it act, and then repeat it after a few minutes to enhance the degree of decongestion you can achieve. As far as the over-the-counter medications are concerned, the combinations that are associated with anything sedative, and you should read the cautionary notes on these packagings. If anything suggests that don't use heavy machinery after taking this, then you know this is likely to lead to sleepiness. The problem is not the sleepiness. The problem is the side effect of some of these allergy medications that are included in these over-the-counter medications. The older generation of allergy medications tend to cause drying of mucus secretions. And so if you've taken a dose of Benadryl at night, you may have fallen asleep, but you'll probably wake up in the morning feeling far more congested and stuffed up than you were going to bed. The thickening of secretions can actually lead to plugging of sinuses and lead to a secondary bacterial infection. But more importantly, it goes back to what I said earlier, in that it leads to drying and thickening of secretions, which can actually worsen cough. So if you have to pick something, the indication to use an over-the-counter medication is really only if secretions that originate both from the upper and perhaps even the lower airway are thick and viscid, regardless of their color. If you have thick secretions, then the only medication that would maybe suffice would be the plain Mucinex or the plain Robitussin or the plain Welltussin or the Civitussins, whichever expectorant there is, but the only generic ingredient in there is guaifenesin. It's not the best tasting medication as a liquid, but certainly a dose or two would be helpful through the day to help reduce the viscosity or the thickness of secretions. A note of caution: don't use this medication about 2 hours prior to bedtime or the anticipated bedtime, because there is so much of drainage that occurs as a result of the breaking down of mucus from the sinuses that is going to worsen the cough overnight, or you have to keep swallowing and swallowing and swallowing, and certainly will delay sleep. The respiratory support and oxygen that I mentioned is really supportive therapies. If there is ongoing use of non-invasive ventilation, that needs to be continued. In fact, that might actually provide some respiratory muscle rest if you extend some of that use in the day as the situation warrants. Some people who use SIP ventilators in the day might prefer to use their nasal mask during the day and not switch off their nocturnal ventilation modes to the SIP ventilation modes, and that's not unreasonable. I ask that you be careful while eating and drinking, and try not to use the nasal mask ventilation during the process of eating, because we'd hate for food to get blown into the airway if the timing of the swallow is off from the mechanical breath that enters the airway. So as far as positive airway pressure therapies are concerned, this is something that I ask your considerations on. What many people don't realize is that there is the potential for increased dissemination of infection in the entire room with the use of positive airway pressure therapies. And going back to the previous SARS coronavirus and the MERS coronavirus outbreaks, what we've learned is that the incidence of the spread of infection in Toronto during the 2002 SARS outbreak showed that 50% of the cases occurred in healthcare workers because of the nebulizer therapies and respiratory therapies that were being performed, despite all safety protocols. That means garb and gowns. So this is an important consideration even in our hospital at this time, that in fact, some of the anesthesia foundations and the sleep medicine foundations have all put out statements to healthcare workers to be very, very careful during airway manipulation as it relates to the current COVID infection. There's always reason to hope, right? So there are some trials that are ongoing Remdesivir is an antiviral agent, and there is an active trial right now in Nebraska in adults who are hospitalized. It's a randomized control trial. There's some trials that are beginning now in adults in Seattle as far as the COVID vaccine is concerned. A number of other antivirals have been brought to light for potential consideration. Baloxavir is a broad-spectrum antiviral. The trials have not yet started, and they're considered for initial phases in China. A couple of other combination therapies have been tried, lopinavir and ritonavir. These are used in HIV infections, but the RCT, randomized control trials, have not shown any current benefit so far. Tamiflu or oseltamivir has not shown to have any data, and I know that there's a tendency to try what you have. Personally, I've always recommended to my families to keep a prescription home for Tamiflu in case there's inclement weather and you experience typical flu-like illness symptoms, to start it rather than wish you had started it. But I don't think I would recommend anything differently because we are still seeing influenza permeating itself through the community. Remdesivir is, like I mentioned earlier, is perhaps the most promising available antiviral right now. It's not commercially available, but there is some statement of compassionate use for DoD personnel. As far as supporting agents are concerned, we just heard about glucocorticoid therapies. The World Health Organization and the CDC have put out a statement that do not recommend the use of this for routine COVID-19 pneumonias or ARDS unless indicated for another reason. And what this means is that in those particular situations where the ICU physicians feel there may be a need, it may be one of the last resort therapies to help contend with what they call is a cytokine shock or a release of chemicals that provoke inflammation through the body. Monoclonal antibodies that have been used in a variety of collagen diseases have no promising data at this time. Dr. Villa has already talked about ACE inhibitors and the use. I will not go over that. And I mentioned ibuprofen or other non-steroidal anti-inflammatory agents don't have any compelling evidence to support any association between the use and negative outcomes, but there is a leaning towards not recommending ibuprofen as a first line for fever control therapies. In the meantime, what do you do? I think, we continue to advocate being practical, hand hygiene, social distancing, not social isolation, but social distancing, and then personal isolation when you have concerns about your own health or that of others. There are ongoing testing limitations through the nation. Some areas are prioritized higher than others, so testing kits are being delivered in greater quantities to areas where the concerns are highest. Ohio, at least for us, is kind of at the bottom end of the list at this time. But nevertheless, even if running a test, there's a variable amount of efficacy in the tests that give you results within the first day or two versus those that take 5 to 6 days. Be aware of your environment. If you are going out, you go out because you need to go. There are real reasons for this quarantine to be recommended, and it's really important that you safeguard healthcare providers in this manner. And then err on the side of caution and exhibit some personal restraint when it comes to the temptation of socialization. With that, I think I would open it up to questions or the committee members. Thank you for having us.
Great. Thank you so much. So at this point, we're going to go ahead and shift into more of a Q&A session format. So I know a lot of you have already submitted questions in the chat box. We appreciate that. We're going to get to as many of them as possible. If you also have additional questions you'd like to ask, go ahead, type them in there, and we will just get through as many as we possibly can. We've gotten a ton of questions about the use of chloroquine, hydroxychloroquine, what that does to QT interval, use of Z-Paks, how these things all come together. So maybe, Dr. Villa, you could start us off. I know that you answered a little bit of that in the chat box already, but maybe you could talk a little bit more about the use of those drugs and what it does to the heart and what are things that we should consider monitoring for if we were to be on Z-Pak, things along those lines.
Yep, perfect. So the biggest worry we have is for what's called the QT, which is basically the time it takes your heart to reset after an electrical beat. And a number of medications can do it, actually very commonly used ones, but azithromycin and chloroquines can prolong that. And if that gets very long, your heart can basically be in reset mode that can set you up for an arrhythmia. And so anytime we have anybody on any medications, including Z-Paks and or chloroquines, we just recommend that they talk to their physicians and say, hey, what is the risk that my QT could be long? And they may say, hey, it's relatively low or it's higher, and we would recommend an EKG to be able to track that because you wouldn't necessarily be something that you could feel. And so really it's just being aware of what medications you have, engaging with your providers for what other risks you may have, and then deciding on how to follow that up if you do start those medications or other medications.
Great. And are these drugs that we would want to consider for our non-Duchenne family members if they were to have the infection?
That's a good question. So right now, I agree with what Linda responded in there, which is everything is very theoretical right now. There are a lot of potential side effects that can happen from it. The access for people who need it for other reasons is being limited. So I'd say unless you're in a hospital setting or have another indication for those medications, I would be weary in doing it for a number of reasons.
Perfect. That was really helpful and clarifying. Thank you so much.
Plus,
so we've also got...
Hey, honestly, I'm going to add, I don't think you're going to be able to even get it, to be perfectly honest with you. We've had a number of families request that, and most of the pharmacies, at least in the Columbus, Ohio area, are back ordered. The State Board of Pharmacy actually is now limiting the prescription for this unless you can actually document that you have a true need for those medications. So I don't think you're going to even be able to get it, even if you wanted it at this moment in time, unless you're going to get it from an inpatient type of setting.
Okay, great. That actually leads to another question, and maybe Dr. Crick, you can start us off on this. So what do we do if there are drugs that we take that tend to be on short supply or become back ordered? Is there any sort of guidance that you could provide us for if we were to find ourselves in that situation? And then to tack on to that, is asking our physician for a 3-month prescription instead of a 1-month prescription something that you would encourage us to do if we find ourselves isolated for a longer period of time?
I mean, I think there's really no reason for the drugs that the majority of us use on a daily basis to be back ordered. And just like the grocery stores, the pharmacies are going to remain open. I think anticipating your next month's refill is appropriate. And if you want, asking your physician for a 90-day supply is fine as long as your insurance carrier is willing to cover that, I think is very appropriate. I think it comes back to common sense and hoarding toilet paper. In some regards, I don't think that we necessarily need to hoard our drugs. There's no indication that there's going to be a shortage of ACE inhibitors, diuretics, prednisone. Those are drugs that will be there. The only thing I would do is, send your prescription into the pharmacy maybe a week earlier than you normally would have.
Okay, that's perfect. One of the questions that we got that I think is kind of along those same lines is, how do we make sure that we have enough Emflaza, because we can only get a 30-day supply at a time. So I think there are probably a lot of you on the line whose sons take Emflaza, and so this is probably something that you've thought about and considered. I would encourage you to go to our website. We have our COVID-19 landing page at parentprojectmd.org. Go ahead and go over to that page. We've got this statement from PTC about Emflaza and access to Emflaza. So currently we don't anticipate any issues with the supply chain, and there is a good amount of drug here domestically that they have access to continue to disperse. But if you have any questions about Emflaza specifically, I would encourage you to go ahead and work with your clinic and work with any points of contact that you have at PTC Cares to figure out what that looks like and if any changes need to be made as well. So in that line of thinking, we've got lots of questions about these steroids. So Dr. Scavina, I'm going to call on you to help us kind of work through some of these questions. So one of those is, what if we need a stress dose of steroids and we're keeping our child at home because there maybe is insufficient bed space at the hospital? How would we get that stress dose if our son is sick but he's still at home?
So I spoke with our endocrinologist even this morning just to make sure that I'm providing you all with the correct information. And I know in our institution, they will often, well, not often, but they try to always make sure that individuals have intramuscular supply if that needs to be administered to a child, or additional oral steroids for a stress dose. So I would encourage you to speak with your endocrinologist if they're providing that to you, or a neuromuscular specialist, so that if it's additional prednisone, they can work with the insurance companies. If it's an IM, if you're concerned that there may be inability, because of vomiting or fluid intake for a child to receive it, that you have that. And that is something that I will often discuss with our endocrinologists as they have their dosing and they know the children well as well and can provide those. I know sometimes it is tricky, even in our system, to order the Sol-U-Core test, the intramuscular, but they've been helpful in doing that for families in our clinic.
That's great advice. I think I'll just reiterate, work with whomever is prescribing that for you, whether it's your neuromuscular doctor or your endocrinologist, and have that conversation now so that you know what that plan looks like, whether it's having a prescription at the pharmacy or if you have the dose at your home already just in case, so that you have that plan in place if you find yourself in a situation where you need to use it. So Dr. Scavina, maybe you could talk a little bit about how to determine which stress dose is most appropriate. And is there any difference if the person is on daily steroids versus weekend steroids?
Yeah, and I went back and listened to your previous webinar. Dr. Wagner from Hopkins, from Kennedy Krieger, I apologize, had spoken as well. And I think for those that on daily dosing to continue, and even weekend dosing to continue. The thought is with the weekend, if you are ill, to consider, and again, I would discuss with your physician first, but consider going to a daily dosing where you take that weekend dosing, divide by 7 for the daily dose, and then looking at if you're having a minor, moderate, or severe. And the PJ Mcclure Protocol will discuss what levels those are and how much additional stress dosing you should receive. So I spoke with her about it too, and I have not switched anyone, or luckily have not had to switch anyone from a weekend to a daily dose. But that's usually in light of maybe a significant fever, vomiting, and where we feel that maybe having a daily dose of protective steroid would be favorable. This is, from what I understand and what I see and read, just mainly respiratory, but I know there have been cases of individuals that have had some vomiting or diarrhea. And then there are also other reasons where children are getting sick at this point in time. And so Is this something that resolves in 24 hours, or is this something persistent? And I think depending on the age of your child or teen or young adult, after 24 hours, if you feel they're not being hydrated well or there's persistent fever, unlike perhaps someone else that does not have an underlying medical condition, to refer to your physician to determine, does that child need to be brought in, or can they be treated at home? Do they need additional IV fluids and a higher dose of stress dose protection?
Perfect. And I do want to reiterate, I see one of the questions here inquires if we should consider weaning our sons off of steroids if they were to have COVID-19. So just to be super clear, if somebody were to have COVID-19 and have Duchenne, weaning them off steroids could potentially open them up to even more concerning problems due to adrenal insufficiency. So with guys that would potentially be in this situation, we would want more steroids. We would want stress dosing to help support their systems. Would you agree with that, Dr. Scavina?
Yes, absolutely. So if individuals find themselves hospitalized, the ICU, the physicians taking care of them should be aware that they're on daily dosing, and if they have fever or increased respiratory needs, should know about stress dosing. I don't think it hurts to advocate, though, and say, hey, my son is on daily dosing. There's a whole protocol for stress dosing. I want to make sure that's in place, because as busy as ICUs may become in emergency rooms, we don't want that to fall through the cracks. And that is something that I've seen happen outside of this COVID episode here that we're in the middle of. So make sure to talk about that, and they should not be stopped, particularly at this time, and should not be stopped abruptly, really any time. There's a way to taper people, but because you have COVID does not mean you should be tapered. And if anything, your body should be giving more of this stress hormone to fight the infection.
Perfect. That was so incredibly helpful. I do want to remind everybody as well that if you go to our website, we can have easily accessible copies of that PJ Nicholas steroid protocol. It's a really, really great tool to have on hand. So make sure that if you are concerned about it, or if you don't already have it on hand, that you go ahead to the website. You can pull it up on your smartphone. You can print it off if you need to go to the emergency room and provide it to those physicians. It's a great tool to have. And then one follow-on question I have for you, Dr. Scavina. Would there be any issue with using prednisone stress dosing if my son was on Emflaza? Is there any concern with potentially having to mix those two medications if I were to find myself in this sort of situation?
I do not believe so, and I will get clarification on that, because I'll have to say that I haven't been in the situation. I don't believe so. I have had times when I've had to go from one day of Emflaza to the next day of prednisone and vice versa. So I do not believe there should be a problem. It is, you may not have batches of Emflaza that you can utilize, but you may have additional prednisone that you can use. So I think that should be fine. I'm going to just double check on that and make sure that we have a clear path for that, and I can get back to you. But I think for right now that would be fine.
Great. And that's something, everyone on the line, go ahead and keep a close eye on our FAQ document that we have on the website as well. We're continuing to update that. We'll update it with all of the questions that we're working through today as well. So that is a living document that we're continuing to just add all of these questions and answers to, so that that's a continual resource that you can go to if you have questions. All right, let's see what other questions we have. Oh, here's a really good one. So is there a number we can call in case our doctor is not available in case of an emergency? I would imagine it would probably be different depending on what hospital my son would go to, but it would be helpful to know what that right protocol would be if I needed to get in touch with my physician.
I mean, I think if I can say all of us have a 24-all. And they should be able to call their on, and the on-call person should be able to direct them or reach out to their neuromuscular specialist or cardiologist or pulmonologist if they really there was something they couldn't answer. That would be my thought.
And, I'm going to put this out there. Every U.S. children's hospital in this country has a pretty user-friendly interface for the most part. I can't imagine that they don't. I know that if you call the children's hospital that I work for and say, can I talk to the cardiologist on call, you will be connected to the cardiology fellow who will answer your questions immediately. All Duchenne families have very similar questions, so you should be able to get answers from those individuals, even though they are not taking care of your son directly. So if you are in one of those situations where you truly cannot get a hold of anyone in your region, pick your favorite children's hospital of choice and give it a shot. Maybe that's not a politically savvy answer, but that's what I would do as a parent.
Absolutely. And I think it speaks to the importance of planning ahead, right? So make sure that you're working with your son's doctor to figure out in advance if an emergency happens, regardless of COVID-19, regardless of bed space, make sure that you know who to call, what that process looks like so that you can be sure to get in touch with somebody if an emergency were to happen. That can be really scary if you don't have those numbers already, saved into your phone and ready to go. All right, here's another question. So I know that we're talking a lot about our boys right now, but what about carriers? Do we think that they are considered to be high risk if they were to come down with COVID-19?
I think everybody can answer, but again, I think that the risk would be similar to any of us, and some of the risk factors, age that have been discussed already, hypertension, asthma, underlying medical conditions would be at play. If they do have cardiomyopathy, if they're older individuals who are carriers, the cardiologist can correct me, but I think would increase their risk of problems. But other than that, I think that if in a younger patient, in the pediatric patients that I see, I'm recommending all the same precautions as every other child.
Yep, and I agree with that. And I think the most important part from our perspective for where we see issues from a carrier perspective is making sure that the adult providers know what the typical imaging findings and the cardiovascular findings overall in carriers are, because we see a number of people, especially if they're worried about myocarditis, which is one of the things that has been raised in the adult literature for COVID-19, is know what a typical MRI looks like for a carrier, or if you have previous MRI findings, what that looks like, because it can confuse them in terms of the diagnostic approach and how things usually look for a carrier and how that may look or be interpreted to say you have myocarditis when it can be more of the typical dystrophinopathy pattern of MRI. And if anyone has questions about those, I know Linda and I get those a lot, so we'd be happy to go through stuff, but just make sure those adult providers, if they're not used to looking at carriers imaging, can reach out to centers that have some expertise to help them go through what might be viral infection of the heart versus the more typical findings of a carrier.
I completely agree, and I want to add one more thing. I think, and this can be somewhat comforting to at least families with younger children. For whatever reason, youth seems to be protective against severe disease with this virus. I was on a call yesterday where they were discussing data that's coming out of the Children's Hospital Network, and very few admissions are related to COVID-19. I think that can give you some comfort. I don't know if it will pertain to the Duchenne community moving forward, but I think that the younger children are sorry, my dogs are barking, but the younger children are somewhat protected.
And also to go towards that, and because people were asking about the steroids and the potential immunosuppressive effects, I think we have all been pleasantly surprised so far that even transplant patients who are on a lot of immune suppressants, even more than steroids, in addition to steroids, so far in Italy, in China, and other things, we have not seen that get significantly worse, this is a good example of where, as we get more information, checking with PPMD, checking with Action, which I linked on, we are going to be rolling that out to families as we get it, if that changes. But I second that from Linda's perspective, which is staying away is important as much for your own benefit and health as for your boys or for the young men, because we may all be more at risk than some of the younger children so far.
That's fantastic, Dr. Bill. I think that's actually, go ahead, Dr. Sonani.
I just want to add, through our clinic visits, we always find our young boys tend to be, quote unquote, the healthiest ones in the household. And given that if you think about this as a bad, but it's still a cold and flu virus, a part of me feels that I should be prepared to see a similar theme over here. And in email communications to our colleagues in Europe, no one has seen their Duchenne patients or their neuromuscular patients do any different with this strain, if they caught it, than they normally would have done otherwise. So we're not seeing something tear through the neuromuscular community in the European population. So it gives me, hope that we might be okay. Go ahead.
No, I think that was really well said, and I think we all need a little bit of hope right now. So I think, honestly, that's a really good place to end. So thank you so much for that. A couple of housekeeping announcements. I know that earlier in the webinar, somebody mentioned the emergency app. So there is a PPMD emergency app for your phone that you can download. The link is on our website. I would encourage you, if you don't already have that, to go to the website, check it out, download it so that you've got that emergency information with you easily on hand if you were to ever find yourself in a COVID-19 related emergency or otherwise. It's got things about the steroid dosing, things to tell the emergency doctors about breathing and all of these different considerations that we need to keep in mind. But when we're in emergency situations, it's really easy to forget. So I would encourage each of you to go and take a look at that. And while you're there, we actually, within the last few months, launched our new registry platform. So if you're not already in the registry, I know a lot of us have some extra time on our hands as we're self-isolating and social distancing ourselves at home. Go ahead and take a look at that as well and consider joining that app if you haven't already and filling out some of those surveys. So coming up, to keep your eyes out, we're going to keep doing these weekly webinars about Duchenne and COVID-19. We're keeping an eye on themes that emerge and questions that you all have, so please keep them coming. You can reach out to us on Facebook. You can send us emails. We're happy to take those questions, and we're trying to really address these concerns as we see them. So next week, Wednesday at noon, we're going to have an adult-focused webinar. So Duchenne adults and COVID-19 implications, that population does have some more unique risk factors, so we're going to tackle that head on. The following week, we're going to look at managing anxiety and stress. I don't know about you guys, but I have found my anxiety at an all-time high managing everything that's going on right now, so we're going to have some folks on to talk about managing our own stress and anxiety, as well as the stress and anxiety of our boys. And then from there, we're probably going to dive into access and clinical trial issues. We've still got some things in the works, but we want, again, to let you guys know that these are things that we're thinking about. They are things that we're planning. So please continue to let us know what's on your mind, what's going through your head, and how can we help support you as much as possible. And then the last thing that I'll share, this is being recorded today. So here within the next several hours, we'll get this pushed out online so you can go back and re-listen if you would like to, if there was a point of clarification. Share it with family and friends who might be concerned, and just know that those resources are there and available through that COVID-19 landing page on our website. So with that, I'll go ahead and wrap it up. I know we're a few minutes over, so thank you everyone so much for joining us today. We really appreciate having you tune in, and we'll talk again soon. Thanks, everyone.